Welcome, everyone, to an informative journey into the world of Alpha-1 antitrypsin deficiency, specifically focusing on its impact on the lungs. This often overlooked condition can significantly affect respiratory health, and understanding it is crucial for early detection and effective management. Join us as we explore the causes, symptoms, diagnosis, and treatment options for Alpha-1 antitrypsin deficiency, helping you gain a deeper understanding of this complex disorder. At its core, Alpha-1 antitrypsin deficiency, or Alpha-1, is a genetic disorder. It's caused by mutations in the SARPANA1 gene, which provides the instructions for making Alpha-1 antitrypsin, or ATE, a protein produced in the liver. This protein acts as a critical protector, primarily neutralizing an enzyme called neutrophil elastase. Neutrophil elastase is released by white blood cells to fight infection, but it can also damage healthy lung tissue if left unchecked. Individuals with Alpha-1 inherit faulty versions of the SARPANA1 gene from their parents, leading to either insufficient production of ATE or the production of a dysfunctional protein that can't effectively protect the lungs. Now, let's delve into the mechanics of how this deficiency harms the lungs. Without sufficient functional ATE, neutrophil elastase runs rampant. This enzyme starts to break down elastin, a key component of the lung's structural framework. Over time, this leads to the destruction of the alveoli, the tiny air sacs in the lungs where oxygen and carbon dioxide exchange takes place. This destruction results in emphysema, a condition characterized by irreversible damage and enlargement of the air spaces in the lungs. The loss of elasticity makes it difficult to exhale properly, leading to breathlessness and impaired gas exchange. In addition, the misfolded ATE protein can build up in the liver, potentially causing liver disease. Alpha-1 antitrypsin deficiency is a relatively rare condition, but its true prevalence may be underestimated due to underdiagnosis. It's estimated to affect about 1 in every 30,000 to 5,000 individuals of European descent. However, it can occur in people of all ethnicities. Because the symptoms can mimic other respiratory illnesses like asthma or COPD, many individuals with Alpha-1 remain undiagnosed for years. Early detection is crucial, as it can allow for interventions that slow the progression of lung disease. The signs and symptoms of Alpha-1 involving the lungs can be varied, and they often develop gradually. Shortness of breath, especially during exertion, is a common early symptom. Chronic coughing, wheezing, and increased mucus production are also frequently observed. Individuals may experience frequent respiratory infections like bronchitis or pneumonia. Over time, symptoms can worsen, leading to significant limitations in physical activity and a reduced quality of life. Because the symptoms are similar to COPD or asthma, Alpha-1 is often initially misdiagnosed. Diagnosing Alpha-1 involves a combination of clinical evaluation and laboratory testing. If a healthcare provider suspects Alpha-1 based on symptoms, family history, or an early onset of emphysema, they will typically order a blood test to measure the level of A8 in the blood. Low levels of A8 strongly suggest a deficiency. Genetic testing can then confirm the diagnosis and identify the specific SARPANA1 gene mutations present. This genetic information can be important for understanding the severity of the condition and for assessing the risk to other family members. While Alpha-1 is primarily classified based on the presence and severity of A8 deficiency, different variants of the SARPANA1 gene can lead to different levels of A8 production and varying risks of lung disease. The most common deficient alleles are PZ and PIZ. Individuals with the PZ genotype, inheriting 2 copies of the PIZ allele, typically have the lowest levels of A8 and are at the highest risk for developing lung disease. Understanding the specific genotype can help doctors tailor treatment strategies. Currently, there is no cure for Alpha-1 antitrypsin deficiency, but there are treatments to manage the symptoms and slow the progression of lung disease. Augmentation therapy, also known as ATE replacement therapy, involves intravenous infusions of purified human ATE derived from plasma donors. This aims to increase the AAT levels in the blood and protect the lungs from further damage. In addition, bronchodilators and inhaled corticosteroids can help to open up the airways and reduce inflammation, similar to treatments for OP. Pulmonary rehabilitation programs, which include exercise training and education, can improve lung function and quality of life. For severe cases of emphysema, lung transplantation may be considered as a last resort. Unfortunately, there is no way to prevent Alpha-1 since it is a genetic condition passed down from parents to their children. However, individuals with Alpha-1 can take proactive steps to protect their lungs and slow the progression of the disease. Smoking is extremely detrimental and should be avoided at all costs. Exposure to other lung irritants, such as air pollution and occupational dusts, should also be minimized. Regular vaccinations against influenza and pneumonia are essential to prevent respiratory infections. Maintaining a healthy lifestyle, including a balanced diet and regular exercise, can also help to support overall lung health. The prognosis for individuals with alpha-1 antitrypsin deficiency varies depending on factors such as the severity of the deficiency, the presence of lung disease, and lifestyle choices. Early diagnosis and treatment can significantly improve outcomes. With appropriate management, many individuals with alpha-1 can lead active and fulfilling lives. Research continues to explore new and improved therapies, including gene therapy approaches that aim to correct the underlying genetic defect. These advances hold promise for the future treatment of alpha-1 antitrypsin deficiency.